Good evening, everybody. Welcome to the Stanford Care monthly community health talk series. My name is Dimpi Desai, and I'm a clinical assistant professor in the Division of Endocrinology. I'm very pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. I'm very pleased to welcome Dr. Mindie Nguyen, who will be speaking on the topic liver disease in Asian Americans, what to look for. Chronic liver disease and liver cancer are surging in the United States, and the Asian Americans and the Pacific Islanders are affected by it. Dr. Mindie Nguyen will discuss the latest research and clinical trials that highlights these unique risk factors and disease patterns observed in Asian Americans. She'll talk about the early signs of liver disease, regular screenings, and latest advancement in the treatment options. Dr. Mindie Nguyen is a professor of medicine and, by courtesy of epidemiology and population health, director for the hepatology clerkship, a member of appointment and promotion committee for the professorate line, and a diversity advisor for the professorate faculty search for the Department of Medicine at Stanford University Medical Center. She's an active clinician and researcher performing clinical trials, clinical epidemiology, and real-world studies in viral hepatitis, MAFLD, cirrhosis, and liver cancer, with over 600 publications, more than 300 original research publications, including first or senior authorship in renowned journals such as the New England Journal of Medicine, JAMA Network, Lancet, Gastroenterology and Hepatology, Gastroenterology, Journal of Hepatology and Hepatology. So we're very pleased to welcome you, Dr. Nguyen, and the stage is all yours.
Thank you, Dr. Desai, for the very kind introduction, and hello, everyone. I am very privileged today to share with you the very important topic of liver disease, a disease that really disproportionately affects Asian Americans more than any other ethnic groups. The three most common liver diseases in Asian Americans is liver cancer. On another, you may also see many places who listed as hepatocellular carcinoma, or abbreviation as HCC. Liver cancer is caused by cirrhosis due to any liver diseases and viral hepatitis. So viral hepatitis, A, B, C are the ones that are common, but I will focus more on B and C because these are the two that can cause chronic liver diseases and can cause liver cancer. And then the last but not least at all is metabolic associated steatotic liver disease, or we just call it MASLD. And as of just less than a year ago, this was known as NAFLD, or non-alcoholic fatty liver disease. And one of the main reasons that our field has changed the name from NAFLD to MASLD is to create a more inclusive and non-stigmatizing terminology, taking the fatty word out. Steatotic is just a Latin word for fatty, and removing the alcoholic term in the name. So first, liver cancer, or HCC, and I may use this interchangeably during the talk today. So this is the data to show what causes liver cancer in the world. So globally, the number 1 and 2 in fairly equal proportions is hepatitis B and alcohol, followed by hepatitis C. Now, in high-income North America, the most common cause is hepatitis C to date, 37%, and hepatitis B is only 9%, so not a major cause. However, if you go to East Asia, and many of us here, myself included, are immigrants from East Asia, Southeast Asia, over there, the number 1 cause of liver cancer, 41% is hepatitis B, and next to that would be alcohol. Hepatitis C is about 9%, so not a major cause compared to the other two, but it really depends on which region. For example, in Japan, hepatitis C is a very major dominant cause, and the same as Southeast Asia. But if you go to Taiwan or Korea, then hepatitis B is much higher, but hepatitis C is still an important cause. So how do we diagnose HCC or liver cancer? So the key thing that I would like to kind of emphasize here is that for most cancers, we need to do a biopsy. But fortunately, liver cancer has a very characteristic looks on CAT scan or MRI. So 95+% of the time, we can make the diagnosis very confidently by imaging alone, and biopsy is not indicated. And biopsy, in fact, can be pretty risky because HCC tends to bleed and can tend to also spread with a needle tracks. There are many blood tests can suggest cancer, but it cannot really make the diagnosis because these blood tests sometimes or frequently in some cases can be abnormal in cases of no cancer at all. And in about 30% of liver cancer cases, these blood tests may be normal. So the main diagnosis for HCC is an imaging like CAT scan or MRI. So I want to share with you here an example on how it really looks like. So this is a CAT scan. So it's also important the techniques of the CAT scan and whether the scan would be done properly or not. So you may have heard of cases of people when they do this that we really need to get the imaging, not just the report of the CAT scan. So the first one you can see here, the cancer is not obviously shown in here because you can see this one is a representation of one of our blood vessels and it is dark. So it doesn't have contrast in here. So we can easily miss a cancer here. But in a contrast with good intravenous contrast with this here, being bright. So that tells you that this is a contrast. You can see that the cancer shows up here. So it's very important because sometimes people, it's normal to want to avoid contrast because, it involves an IV placement. There is some risk with contrast, but it is very essential for diagnosis of liver cancer. So what do patients feel when they get liver cancer? So about 25% in general, on average, would have no symptoms. And if the patient has symptoms, the common symptoms would be abdominal pain, weight loss, or liver failure, or we call hepatic decompensation. Now, our goal is that we want to diagnose as many patients at the asymptomatic stage as possible. Because when there are symptoms already, the cancer is already advanced and treatment options would be very limited and survival prognosis is extremely poor in a matter of weeks or months. So the goal really is to do liver cancer screening and surveillance, checking liver ultrasound every 6 months and blood tests every 6 months, even when the patient feels perfectly fine, because that's the only way that we can hope to diagnose the cancer at an early asymptomatic stage so that we can offer good treatment. So to just sort of like put this together, so our first job in the management of liver cancer or HCC is not to treat the cancer, but number one is to identify high-risk patients, enter the patient into surveillance, because if the patient presents too late, then there's really no treatment that the patient can be eligible for. So this is first and foremost. And then you make the diagnosis in patients who have a positive screening test. And then you will stage to see if the patient have early or late stage, liver function is good or bad, because that would determine what treatment the patient can get. And then follow up the patient. So who are the high-risk patients that we should identify to enter surveillance or screening for liver cancer? So the current standard of care is number one, liver cirrhosis. Liver cirrhosis means that the liver is scarred, very scarred. So it's just a term for severe scarring of the liver. And this can be caused by many things: hepatitis B, hepatitis C, alcohol, fatty liver, steatotic liver that is related to metabolic disease like diabetes, and chronic hepatitis B. So chronic hepatitis B is one of the few chronic liver disease that can cause liver cancer without causing severe scarring or cirrhosis first. So this is something very important to remember. And currently, we use liver ultrasound and a blood test called alpha fetoprotein every 6 months. And the reason for every 6 months is that the tumor doubling time for liver cancer is about 6 months. And ultrasound cannot detect liver cancer very well when it's less than 2 centimeters. So if after 6 months, a 1.5 centimeter tumor can become 3, and then at that time the ultrasound most likely can pick it up. But if someone go away for a year, that can become 6 centimeter, and that may be too big for a good treatment at that time. And there are clinical development and research to try to develop better blood tests for liver cancer. And then, as I mentioned earlier, diagnosis, you need a CAT scan and or MRI. Staging, also CAT scan or MRI. And the treatment. So the treatment that will lead to the best outcome is liver transplant. The 5-year survival, meaning that the probability of someone to still be alive 5 years later with liver transplant is more than 80%. For resection, meaning that you do surgery and remove the cancer and the liver surrounding it. So the survival at 5 years for people with resection is about 50%. And the reason why it is lower is because we can take out the cancer, but the disease or the sick liver is still there and it can make new cancer. So that's why with transplant, the patient also get a new liver, and therefore the risk of cancer coming back is much lower. And other treatment would be local therapy. You either use electricity or ethanol injection to just inject into the cancer to kill it, so to speak. And TACE is a abbreviation for transarterial chemoembolization. And this is a very common treatment because many patients don't present early enough to get the other treatment. So when they have more tumors or tumor in many different places, and then what we do is that we would go in and very much like a heart angiogram, that is commonly done for heart disease. This one internally go in and look for the artery feeding that cancer and inject chemo in there. And then we also have systemic treatment, and I will show you a little bit more data on this. And a follow-up is that we follow with blood tests and CT MRI after treatment to just check to see when the cancer come back so that we can treat the patient again. So again, identify high-risk patient for surveillance. So cirrhosis, any cause, any age. For chronic hepatitis B, so for men, more than 45 years old. For women, more than 55 years old per the current liver guideline. But in my practice, I screen my hepatitis B patient with no age limits in adults because the reason why the guideline did not recommend in younger people because there's not enough data to support it. But I have visited and seen many data from East Asia, and certainly young people in their 30s, 40s, and even 20s could develop liver cancer. So as a practice, I offer surveillance to all of my adult hepatitis B patients. And the reason why we are doing blood test and ultrasound at the same time, because neither is a perfect test. So ultrasound can only pick up about 60% of liver cancer on average, and alpha fetoprotein, the blood test, 70%. So by combining it, we hope to increase that more to 80-90% pickup time. And as I mentioned to earlier already, we diagnose with CAT scan, and usually has a very characteristic look and staging. We also check to see if the cancer has gone to the lungs or to the bones. And for follow-up, we usually check every 3 months after treatment. So, the key thing here is you may have heard the theme is that regular checking. regular checking rather than waiting to feel sick already. And best 5-year survival is with transplant. So a little bit to show you what a percutaneous ablation looks like. So you can see that there is a liver cancer here, and then radiofrequency ablation or ethanol injection basically just go from outside to use either CAT scan guided or ultrasound guided to find the cancer and inject right in the middle. And this only works for small tumors. Bigger tumors, the injection or the radio frequency cannot really kill the whole tumors. And therefore, we tend to treat with chemoembolization because with this, we can go in internally, as you can see in this scan here, to find the blood vessel that feed the cancer and ablate, basically starve out the cancer and kill it that way. So bigger tumors, we need to treat with something like this, and the ablation locally does not work for big tumors. How about systemic treatment? There are two different types of systemic treatment. One is to directly kill the cancer, and the other two for people with a liver cancer because of a virus like hepatitis B or C, then we also need to treat the virus. And we have data and study from both the US as well as from East Asia to show that in patients with hepatitis B and cancer, just by treating it with antiviral therapy, we can increase the 5-year survival by 40%, and for hepatitis C by 60%. So it's a big difference. As you can see here, the average or median time survival for people with cancer from Hep C can increase from 26 months to 44 months on comers. So like an 18 months incremental benefit. So a pretty sizable improvement. And this is to share, this is a busy slide, so it's not the details, but to want to share with you that there are many treatments that can be given intravenously or by a pill. And this is for patients who are more advanced and not really candidate for the other treatment. And you can see here the average survival between people who got treated and untreated. You can see the difference is in a matter of 2 to 3, 4 months. So very small. So therefore, to kind of drill on it again, early detection, early diagnosis, and screening surveillance for liver cancer to diagnose the cancer at an early stage is really important, because in late stage, even with all of the advances that we have had in the recent 5 years or so, with all of these systemic treatment, the benefits of treatment cannot be so much because the patient already have very advanced disease. And as you could see here, when you mention in months and the pool data together here is similar to what we see over here, very limited 2 to 4 months improvement in survival, not in years. So again, liver cancer surveillance, early diagnosis can increase early detection, curative treatment, and survival by 2-folds. But unfortunately, the research data show us that only about 30% of the patients are diagnosed at the pre-symptomatic or early stage, and only about 60% have some history of surveillance, and 10 to 30% adhere to surveillance as recommended long-term. So it's really underutilized, and this really needs cooperations of the patients and the doctors to really stay on top of this, because it's a long-term thing, and it's difficult to adhere to something if we feel well. So it really requires understanding and commitment to have a good outcome. And another recent study found that, data from nationwide US data, and this is pretty updated to 2021, only about 9% of patients with liver cirrhosis and 40% with hepatitis B in general got an ultrasound every 6 to 12 months. So in reality, it's a very difficult thing to do because, it's every 6 months, it's a lot of work to go and get all of these things done. And it's costly, it takes time to go see the doctor, etc. So it's very difficult, but it's very important. And I hope I have shared with you the evidence to convince you that is very important. So now let's move to viral hepatitis. So we have hepatitis A, B, C, and D, and even E, but the one that I will focus on, hepatitis B and C, are the two that commonly cause chronic liver disease, and especially in Asian patients. So first on hepatitis B here. So hepatitis B can be transmitted by mother to child, by sexual contacts, and also by blood products exchange, including shared needles. The mortality for acute hepatitis B infection is low, 0.5 to 1% only. But what really hurts is the complications of chronic hepatitis B, such as liver failure after a few decades of infection, and also liver cancer. And how many percent of people infected with hepatitis B become chronically infected? So this really depends on the age of the infection. So if exposed as an adult, 95% will clear the virus and only 5% will become chronically infected. And eventually, a lot of these 5% will also clear the virus on his or her own. But the reverse is true. If exposed as infants or children less than 5 years old, 95% will become chronically infected. And this is why there are such a big reservoir of chronic hepatitis B in areas with a lot of hepatitis B and infected mothers, such as East Asia and in sub-Saharan Africa. We do have very good prevention for hepatitis B. We have extremely effective and safe vaccine. The problem with that is that not everybody utilize it. There's universal hepatitis B vaccine program in the US as well as most developed countries. But the rate of people completing the vaccine series is not just one shot. There are two regimens now. One is 2 shots over 2 months, and one is 3 shots over 5 months. Both of them work very well. The 2-shot one is fairly new, about 10 years ago, and it's not available everywhere. But I strongly suggest using the 2-shot regimen because it's a lot easier and a lot easier to complete the whole series to get protected from it. So everyone, both adults and children should be vaccinated, especially people with liver disease. And even after someone is exposed to hepatitis B, we also have treatment to prevent it, called HB. In terms of treatment, there are many medications for hepatitis B that are effective, but the one that I highlighted in red here are now considered the first line, the better one. The other ones, they either have side effects or risk of resistance, or they don't work very well. So if someone gets started on hepatitis B treatment today, I would only recommend the one that I highlighted in red here. So I alluded already to earlier that, the patient can have acute infection, go to chronic, depending on the age, and then cirrhosis, and then liver cancer. And cirrhosis can cause liver failure, and liver cancer, liver failure can be treated by medications, and that fail, liver transplantation. Otherwise, it could cause early death. And the main thing with hepatitis B is that you can go from chronic infection to liver cancer without bypassing the cirrhosis. So that's why even if there is no cirrhosis, patient with hepatitis B should undergo liver cancer screening. The main problem with hepatitis B is this World Health Organization estimate of about 290 million people worldwide with hepatitis B. It's estimated that only about 10% have been diagnosed and only about 5 million have been treated. So this is a disease that really we need much more awareness from both physicians, doctors, any healthcare workers, public health workers, to really promote screening. So as of March this year, the CDC, our Center Disease and Control, have recommended universal hepatitis B screening for all US adults. We have universal screening for hepatitis C for many years now, as many of you may be aware and been advised to be tested. But for hepatitis B, it just became universal screening this March 2024. That was because in the past, it was based on risk, whether you were born in an endemic area or there's a history of exposure. But that didn't really work because it's difficult to remember all of those risk factors. So the CDC had changed it, and now it should be universal. So if anybody in the US, any adults, regardless of any risk factors, everyone should be tested for hepatitis B. Moving on to hepatitis C here. So this is less common in Asian than than hepatitis B. However, the largest number of people with hepatitis C in the world is actually also from the Western Pacific or the Asia region, because there is a big population in that region. So it is also a very important cause of liver disease in Asian American. For hepatitis C, the transmission is mainly by body fluid exposure, especially blood products, but it's not so much sexual transmission. The mortality for acute infection is also low, like with hepatitis B, 0.5 to 1% only, and 85% of people exposed to hepatitis C will become chronically infected. There is no effective vaccine for hepatitis C, but we now have very, very effective and safe and well-tolerated medications, pill. Patient can take just one pill a day for as little as 8 weeks and can get 95% cure. So this is a breakthrough 10 years ago in 2014 that really has changed a lot. So it's very important to diagnose hepatitis C because we have a very, very good treatment and very, very safe treatment. Because if we don't treat it, hepatitis C can go to cirrhosis and liver cancer, just like hepatitis B. This is a busy slide, but again, just like my slide for the treatment for cancer, this is mainly to show that there are a lot of medications available for hepatitis C that are very safe and can be taken as little as just 8 weeks. And the cure rate on average here is 95%. If the patient have no cirrhosis, the cure rate is almost 100%. Even in patient with liver cancer already, if the patient get the cancer treated first and then Hep C treatment, then the cure rate is 95%. So also very good. So advanced disease like cirrhosis, HCC should not stop patients and doctors from getting treatment for hepatitis C. This is the research that I wanted to highlight. The top one from 32 centers in France, and the bottom one are from a cohort of 245,000 US people who have hepatitis C and got treated. And the data show very clearly that the treatment decrease not only the complications of liver, but also the overall mortality and other non-liver complications that hepatitis C can cause, such as kidney disease and diabetes. So I would like to stress again, very important screening for hepatitis B and C so that good treatment can be used to prevent complication. And the last disease I would like to go over is the MASLD, or metabolic associated steatotic liver disease. So metabolic associated, dysfunction associated it mainly refers to diseases such as obesity, diabetes, high blood pressure, and high cholesterol. So these are metabolic diseases that contribute to development of fatty liver or steatotic liver. So what is steatotic liver or fatty liver? So if we look at the liver with our naked eyes, then this is what it looks like. Normally, the liver would be brown, but you can see here it has a yellowish look to it. It's because it has an abnormally high level of accumulation of fat in the liver. And the common causes, as I already alluded to, obesity, diabetes, high cholesterol, high blood pressure. And usually these diseases kind of go together. So for example, if we are overweight or obese, then we are more likely to get diabetes, hypertension, and high cholesterol. So they kind of go together. And if we look at it under microscope, we can see these white drops here. So these are fat. So these are how fat looks under the microscope. How do we diagnose hepatitis, liver, fatty liver or hepatic steatosis? So hepatitis B and C, we have very good, simple, accurate tests. Just do a blood test, very easy. It's a little bit harder with fatty liver here, because strictly speaking, to really show it, we need to do a liver biopsy and show something like this. However, a liver biopsy is invasive and it can has very severe complication. So it's not practical and safe to do that. So usually in clinical care, we use liver ultrasound or fibroscan. So what is a liver ultrasound? I think is commonly done. So most adults, by the time we are now 40s, probably have had an ultrasound for one reason or another. So very non-invasive, is very non-invasive and very safe and can be done in about, 20, 30 minutes or so. The fibroscan, and I apologize for a typo here, it should be FIBR. So this one is also very safe, very non-invasive, and take only about 10 minutes. So the advantage of the liver ultrasound is that it can actually take a look at the liver, but it cannot tell by itself how much scarring or fibrosis are in there unless the ultrasound is attached to an additional specialized test called elastography. Fibroscan cannot see the liver structurally, but the fibroscan can quantify the amount of fat in the liver and also the amount of fibrosis or scarring. Now, MRI, of course, is more sensitive and more accurate, but it is a much, much more expensive test, and most of the time is not really necessary, but that is an option. And then there are many blood tests that can be done to also check for fibrosis or scarring of the liver, as well as fat amount in the liver. So how common is this? Globally, it's about 30%, but it's projected to be more than 50% by 2040 because it's going up. With the diabetes, obesity going up, the fatty liver, steatotic liver is also going up. In the US is about 35% and is the highest in Mexican American, but in the other groups is about 30%. In Asia, the prevalence is about 30%. So if you think about it, 1 in 3 persons in this room has this disease. So it's very common. This is the data for Asia. So you could see here for mainland China, it's about close to 30% here, Taiwan 33%, Indonesia, and Southeast Asia is the highest. You can see like 40, 50% here. The lowest is Japan, 22%. But even in Japan, it's projected to be more than 50% by 2040. Then there's another thing I want to mention is about the weight. Okay, so there is an index called the body mass index that if you just Google it, there will be calculator. And this is an index to measure to see what is a healthy weight according to our height. Because the taller we are, then, the more weight we can be and still remain healthy. So for Asian, underweight is 18.5, and for other group it's the same. However, the normal range of weight for Asian only go up to 22.9, and for other groups, 24.9. So a body mass index of 23 or higher is considered overweight in Asian, and a body mass index of 27 or higher is considered obese in Asian. And many of my Asian colleagues from Asia, like Hong Kong, Taiwan, Japan, they actually use the cutoff of 25 and not even 27.5. And the reason for this is that the increased risk of death started to get higher in Asian at a lower body mass index. So the inflection point for complications and death due to weight, associated weight, is lower. So it's even harder for Asians to stay in the normal weight range. And it's also known that for Asian, even when the Asian patients in the totally normal weight, the person is at higher risk to develop fatty liver. So that's why it's a very, very common and important disease in Asian. And historically, we used to think that fatty liver mainly occurs in people who are overweight or obese. But the data from 24 countries and from 100 studies and 10 million people here show that of all the people with fatty liver disease, 4 out of 10 were not obese, and 1 out of 5 is totally have normal weight. So being normal weight doesn't mean that we are free of risk of having mass LD, especially if we are Asian. So we really also need to check for other risk factors like diabetes, high blood pressure, high cholesterol, etc. The other important thing I want to stress is that for mass LD, liver disease and complications with liver are only part of the problem. Fatty liver can cause cirrhosis and liver cancer, just like hepatitis B and C. But what is important to know is here, mass LD or metabolic dysfunction associated fatty liver disease can cause heart disease, kidney disease, sleep apnea, many endocrine conditions, and many cancer, the non-liver cancer, colon, gastric, breast, uterine cancer. In fact, the #1 cause of death in patients with mass LD is actually not liver, but heart disease. So for patients with mass LD or metabolic dysfunction associated liver steatotic liver disease, it's very important to not just focus on the liver, but also in other related conditions like cardiovascular disease, etc. And very important to treat the underlying disease like diabetes. So it's very important to work with non-liver doctors to take care of the other metabolic diseases. And this is a problem, not with just hepatitis B, but even worse in the case of fatty liver. So the disease awareness rate for hepatitis B for the US, so I show you the data earlier for global, only 10%. So we do a little bit better here, 20%. So only 1 out of 5 hepatitis B patients in the US is aware that he or she has hepatitis B. It's better for hepatitis C. 1 out of 2 is aware. But for fatty liver here, it's only 5% is aware. Only 5%. So the disease awareness rate needs to be improved for all liver diseases, especially fatty liver disease here. Because if we are not aware that we have a disease, then we don't know to go and get treatment or monitoring. The main treatment now for mass LD is weight loss, diet, exercise, and there are many new and good medications for weight loss now. Bariatric surgery, also very effective, and it has become much more effective and safe. And the approach now can be very minimally invasive. So benefit with even 5% weight loss is important, even in lean people. So weight loss is the main thing. And number two is control of the comorbidities like the diabetes, the high cholesterol, because these can feed into it and make the fatty liver worse. Vitamin E may be used in patients who have biopsy proven fibrosis and inflammation from mast LD. So we call it NASH, or now is MASH, for metabolic dysfunction associated steatohepatitis. So mast LD or fatty liver is just the accumulation of fat, whereas NASH or MASH is that it also has inflammation and scarring in there. Metformin, which is usually used for diabetes, can be used in patients with MASLD, but not in patients with no diabetes. And then similarly for other medications, and there are novel drug therapies in development. There is one drug that was just approved in March this year, but this medication is only approved for people with fibro scarring, like moderate to severe, like stage 2 and 3. And it's fairly new, and our experience and real world data, what is happening in a clinical trials is different from what we may see in real world. But I think that in the coming time, we will have more and more data to inform us of that. So in summary here, the most common liver diseases in Asian Americans are liver cancer, hepatitis B, and MAST LD. Hepatitis C is also an important disease, but not as common. Universal screening for hepatitis B and C are recommended by the CDC for all US adults at least one time, unless there are new exposure risk. Treatment for hepatitis B and C can prevent liver cancer. And we have very good and safe medications for both of these hepatitis. Liver cancer has very poor prognosis. I am talking about weeks to months prognosis if it's diagnosed late. So routine surveillance of liver cancer with liver ultrasound and blood tests every 6 months can double the survival. And I cannot advocate for it strongly enough. So I hope this has been helpful, and I thank you for your attention.
Thank you so much, Dr. Wen, for that amazing talk and for this enlightening information. We do have some questions from the audience. So they're asking about what are the social determinants of health that characterize these diseases.
Yeah, very good questions. So hepatitis B, as well as hepatitis C and chronic liver diseases in general, there are good data from the US to show that the prevalence of these chronic liver diseases are higher in patients with a lower socioeconomic status. And not only that, among people who already got the disease, the people with lower socioeconomic level have higher mortalities. So they are more affected, and once they are affected, they also have higher rate of complications. So there is clearly correlations between socioeconomic status with the disease prevalence and the complications, suggesting that there are barriers to care and areas that could be improved and should be improved to remove the disparities.
Okay, thank you so much. How would patients know whether they have hepatitis A or B or C? Is it all identified through blood work?
Yeah, so we are very lucky that we have very good serologies for hepatitis, for all the hepatitis, A, B, C, D, E. All of them can be diagnosed very easily by blood tests.
Wonderful. If somebody has fatty liver or MAFLD, how do you spoke about treatment, how to avoid it to move to cancer?
Sorry, could you repeat?
If if a patient has fatty liver or MAFLD, you already spoke about the treatment, but how to prevent it from progressing to cancer?
Mhm. Yeah, great questions. So currently, the treatment that is approved, only one drug so far, like you have to have more advanced form of fatty liver disease to be able to be eligible for that treatment. But the prevention here is by weight loss. I have seen many patients come in with abnormal liver enzymes and exercise and diet and lose weight totally normalized. So weight loss has been shown to uh, decrease the complication rate and even can get rid of the fatty liver disease completely. And I saw in the chat there's a question that if you're already lean, meaning that you're not overweight, how can you improve on that if you're already not overweight? So that's a great question. And there is a randomized clinical trials from Hong Kong that that show that even if you are already normal weight and you lose about 5% of your body weight, there will be improvement in the liver enzymes and in your fatty liver disease.
Wonderful. And I think you talked about metformin, but the is does it have any effect on MASLD at all? Even if they have diabetes, does it affect MASLD?
Yeah, so currently there's not sufficient data to recommend metformin in patients who have no diabetes. But if the patient have diabetes, then metformin is one of the medication that can be considered. Now, metformin is one thing that was mentioned in the guidelines, so I wrote it there. But there are three medications that I really want to mention. Metformin is one, and there are two: statin for cholesterol and aspirin. So all of these three medications have been shown to decrease risk of liver cancer in people with fatty liver disease. And I think that sorry, I want to mention the statin because I have so many patients get statin from their primary care doctor or endocrine doctor and don't want to take it because they have liver disease. Because the package inserts say statin can cause liver disease. So sorry. But serious liver disease from statin is very rare. So my I always try to tell them, please, please try the statin. Follow your other doctors because statin is important. It can help liver and it also protect the heart and other things.
Yeah, thank you so much for clarifying that for the audience. Um, how is hepatitis C screened? We talked about the blood test, but are there any risk factors that they should look for in their blood test, such as elevated liver enzymes? Would the ALT be elevated?
Okay, so I think these are two separate issues. So number one is to diagnose the disease. So you diagnose the hepatitis B and C by blood test. So then now you know, is it Hep B, Hep C or not? So if the patient have hepatitis B or C or have fatty liver, so then the next step is to see the severity of the liver disease. Okay, so the severity of liver disease would be diagnosed by fibroscan, by blood test, by the physician physical examinations. So, I would encourage the patients, if you have opportunity to see your doctor in person, you go. Because nowadays, it seems to be so easy to just, do a Zoom meeting. So, because many tests can be done and the doctor can see it. But the physical examinations can pick up signs of things that the test cannot. So it's a comprehensive evaluation based on imaging tests, blood tests, physical examination, etc.
Thank you. There's another question about the weight and the MASLD. So your slide said 40% of people with the MASLD may have normal weight. So How do we explain that? And then in those patients, are the rates of diabetes, blood pressure, hyperlipidemia also lower?
Yeah. So the people who 40% is people who are not obese. So that includes overweight. And the percent for people who completely have a normal weight is 20%. Okay. And that is a great question. So it depends on a number of factors, and it's an area that is undergo very intensive research. People just started to recognize it more in the last 10 years or so. So sometimes it's because a patient have diabetes or metabolic disease. So, it's a metabolic disease, and obesity is just one of the metabolic diseases. That's one. And number two is genetic. So it's very well characterized that there are certain genetic phenotypes that are more prone to it. And Asians tend to have that phenotype. Mhm.
Wonderful. There's some questions about epidemiology. One is, why is the Asians or Asian Americans more prone to these hepatic diseases? And any difference in the prevalence between male versus men versus women?
That's very, very good question. So hepatitis B and C, men are more affected. And not really, and there's a lot of study to try to understand this. Is it some relation to the sex hormone? But nothing is not very conclusive. But for some reason, if you look at any groups of patients with chronic hepatitis B or C, almost all the time you will find that about 70% are men. So it seems like men are at higher risk for more advanced disease. And something that is very established among people with hepatitis B and cirrhosis is that men is about 2 to 4 times higher risk of liver cancer than women. And that one is pretty well recognized. Um, Fatty liver, the difference between male and female are a little bit less than with viral hepatitis. And the risk factor for fatty liver disease or steatotic liver disease, we already talked about obesity and diabetes, etc. For hepatitis B and C is exposure risk. For hepatitis C in Western countries, most of the risk is from injection drug users or snorting cocaine. In older patient is from blood transfusion, but younger patients, blood transfusion is not really the cause anymore. For people from developing countries, people from Asia, from Africa, from South America, a lot of the hepatitis C is iatrogenic exposure, because in developing countries, there were not sufficient resources to sterilize medical and dental equipments in between patients. And that is why it spread among patients. For hepatitis B, similarly, the same thing that spread Hep C can also spread Hep B. But one of the biggest way that Hep B transmit in Asia or Africa is from an infected mothers to the babies.
Okay, thank you. What community programs are available to help increase the education for patients to be more aware about hepatitis?
Mm.
Any community program?
Yeah, so I would direct your attention to hepatitisbfoundation.org. So that they are based in Pennsylvania. They have a lot of resources. That is translated into many languages. So I would strongly recommend that you go there. That's one. And then the many American Liver Foundation, the ASOD, the American Liver Society, they also have some resources. The ASOD targeted more to healthcare providers and to some extent to patients, but the hepatitisbfoundation.org and American Liver Foundation target more to community workers, health workers, and patients and families, caregivers. So the Asian Health Foundation AHF, the Asian Health Foundation, also have many resources online, and they also have a lot of online lectures, and webinars that you could look. So like today, we talk about 3 diseases in 30, 40 minutes, but there are, a webinar that will dedicate a whole hour on just one of these diseases.
Thank you for sharing that resource. Since COVID happened, do you think that the incidence of hepatitis B and C have increased due to lack of access to healthcare?
Yeah, that's a great question, and one that I studied. So the incidence, which is the number of new cases. So I don't think that they are increasing, for hepatitis B, assuming that we have, like similar immigration rate, because 80% of our hepatitis B in this country is imported from other areas. For hepatitis C, with the opioid epidemics, so there is an increase in new cases of hepatitis C in young people because of that. So the pandemic per se probably did not increase or decrease, the number of new cases. But the problem is the number of percent of diagnosis of the infected people really took a nosedive, because like the healthcare, everything is interrupted, with limited healthcare for the first 1.5, 2 years or so of the pandemic. So we have studied that, so we saw pretty steady rate of hepatitis B and C diagnosis year by year, and then 2020, 2021, on the way down. So we know that these cases did not just disappear, right? And in fact, during pandemic, patient cannot really go in or out of the US much. So we know that the underdiagnosis are probably even worse, because of the pandemic. So we will have more to catch up. Mhm.
Thank you. And for the last question, within the Asian population, is there a specific Asian population that's at higher risk than the others, like Chinese, Taiwanese? Is there a particular that's higher risk?
Yeah, that's a great question. So according to the California Cancer Registry, the Asian group with the highest rate of cancer is Vietnamese Americans. And I think that is because Vietnamese Americans have very high rate of both hepatitis B and C. And then next to that, with the last data that I looked at, is Korean American, and then Chinese American. And some of this is also because Chinese American is a much more heterogeneous group. So we have Chinese American who came here as immigrants, but we also have a large number of Chinese Americans who've been here for 5 generations. So the rate of liver diseases in Chinese Americans are more heterogeneous. In some group, maybe not very high. In some group, it's higher. Whereas like Vietnamese Americans and follow Korean are relatively newer comers. So most are immigrants, and their disease epidemiology is more the epidemiology of the home countries. Mm-hmm.
All right. Thank you so much. And with that, our time is up. It's 8. We're sorry we couldn't get to all the questions, but thank you everybody for attending and for the wonderful questions. And big thank you to Dr. Nguyen for this excellent talk, and for answering all the audience questions. We really appreciate you. Thank you.
Thank you, and have a good evening. Mm-hmm.
Bye-bye.